Hey everyone, and welcome to PTCB Prep Guide. If you're here to absolutely crush the PTCB exam, then you have landed in exactly the right place. Let's get right into it.
In this guide, we're tackling one of the trickiest topics, cardiovascular drugs. But don't you worry, we're going to break it all down in a way that's super simple, visual, and actually easy to remember. We're talking no fluff, no feeling overwhelmed, just the absolute must-know essentials to help you ace that pharmacy technician exam. Feeling like you're drowning in cardiovascular drug names? Yeah, I get it. The list can seem totally endless, right? It's a lot. But stick with me, because we're about to slice right through all that noise and give you a super clear, focused path to mastering the stuff for your exam. All right, first up, let's talk about regulating pressure. We're starting with the real heavy hitters in blood pressure management, the drugs that go after something called the renin-angiotensin-aldosterone system, or RAS for short. You got to know this for the PTCB. It's absolutely foundational. Okay, so first on our list are the ACE inhibitors. And here's the #1 trick to remember them. Just look for the suffix pril. Seriously, if you see lisinopril, enalapril, ramipril, anything ending in pril, boom, you know it's an ACE inhibitor. So how do they work? Well, they block the body from making this substance called angiotensin II. Less of that stuff means your blood vessels can relax, and that brings the blood pressure down. Simple as that. And check this out. Here is a fantastic memory trick. For the exam, the side effects are right in the name of the class, ACE. A stands for angioedema. That's a really serious swelling, especially around the face and lips. C is for that classic nagging, dry cough that just will not go away. And E is for elevated potassium. I'm telling you, these are super high-yield facts. You're definitely going to want to lock these in. Okay, now let's build on that. The next class is super related. These are the angiotensin II receptor blockers, or ARBs. And guess what? They have their own easy suffix, sartan. So if you see losartan, valsartan, olmesartan, you know it's an ARB. They basically work just one step down the pathway from the ACE inhibitors. Instead of blocking the formation of angiotensin II, they block where it's trying to attach. They block the receptor. The end result is pretty similar, though, lower blood pressure. Okay, pay close attention here, because this is probably the #1 question you'll see on the exam, comparing these two drug classes. They share a lot of the same risks, like high potassium, but the main difference, the one they love to test you on, is the cough. ARBs have a much, much lower risk of causing that annoying dry cough. That's why you'll often see patients who can't handle a pril get switched over to a sartan. Super important distinction. Okay, so we've talked about pressure. Now let's talk about pace. We're shifting gears to drugs that control the heart's rate and rhythm. All right, let's meet the beta blockers. I like to call them the olol family. You've got metoprolol, atenolol, propranolol. See the pattern? They all end in olol. So what do? They block the effects of adrenaline, which, slows down the heart rate and helps lower blood pressure. Now, there's a key difference you got to know within this class, and it's called selectivity. Some are beta-1 selective, which means they're laser-focused on the heart, but others are non-selective, meaning they can affect other places in the body too. And the big one to remember is the lungs. So for the exam and for real life, safety is everything. With beta blockers, it's non-negotiable. You've always got to monitor the patient's heart rate and blood pressure. Another huge point is that they can actually hide the symptoms of low blood sugar, which is a big deal for patients with diabetes. And remember what we just said about selectivity? Well, that's why non-selective beta blockers like propranolol have to be used really carefully in patients who have asthma, because they can affect the lungs. Up next, calcium channel blockers, or CCBs. For the test, you just need to know the two main flavors. First, you've got the dihydropyridines. The big one here is amlodipine. These guys mainly work on the blood vessels, relaxing them to lower blood pressure. Then you've got the non-dihydropyridines, like diltiazem and verapamil. These work more on the heart itself, with the main goal of slowing down the heart rate. Okay, let's talk key counseling points. This is prime PTCB material. For the dihydropyridines, like amlodipine, the side effect you'll hear about most is peripheral edema, which is really just a fancy way of saying swelling in the ankles. Now, for the non-dihydropyridines, diltiazem and verapamil, the main thing to watch out for is that they can really slow the heart rate down. And while we're on vasodilation, we should mention nitrates, like nitroglycerin, used for chest pain. Patients need to know it can cause headaches and low blood pressure. And, this is huge, it absolutely cannot be taken with PDE5 inhibitors. All right, let's dive into managing fluid volume. We're talking about diuretics, which you've probably heard called water pills. And that's exactly what they do. They help the body get rid of extra salt and water. And by doing that, they lower blood pressure and are a huge help for conditions like heart failure. So there are three main types you've got to know. First, thiazides, with hydrochlorothiazide being the most common one. Then you have the loop diuretics, like furosemide, which you probably know as Lasix. These are way more potent. For both of those, you have to keep an eye on potassium levels because they can make them drop too low. But then you have the third type, potassium-sparing diuretics, like spironolactone. And just like the name says, they do the exact opposite. The risk here isn't low potassium, it's high potassium, or hyperkalemia. Okay, time to switch gears to a class of drugs you will see all the time. I mean, these are some of the most prescribed medications in the world. We're talking about the statins, and their main job is to take on high cholesterol. This one's a gift when it comes to memorization. The suffix is literally in the name of the class, statin. Atorvastatin, simvastatin, rosuvastatin, it's right there. They all work by blocking an enzyme in the liver that's responsible for making cholesterol. So less enzyme activity means less cholesterol. Now with statins, the safety warnings are absolutely critical. You'll need to know that we monitor liver function. But the biggest, most important counseling point is telling patients to report any new or unexplained muscle pain right away. This is because of a rare but super serious risk of severe muscle breakdown called rhabdomyolysis. Oh, and here's a little tidbit for the exam. Lovastatin works best when it's taken with an evening meal. Okay, we're on to our final major category, mastering blood clots. And in this group, we have two different but closely related types of drugs, antiplatelets and anticoagulants. Let's break them down. So what's the actual difference? It's a great question. Let's make it simple. Think of antiplatelets, like aspirin or Plavix, as making your platelets less sticky. They prevent the platelets from clumping together in the first place. Now, anticoagulants, like warfarin or Xarelto, they work on the actual clotting factors that float around in your blood. They interfere with the chemical chain reaction of forming a clot. So they both prevent clots, they just attack the problem from two different angles. Okay, this slide is huge for the PTCB. It's the old school versus new school showdown, warfarin versus the newer drugs called DOACs. The biggest difference is monitoring. Warfarin, which is also called Coumadin, is high maintenance. It requires constant blood tests called INRs, and patients have to be super careful about how much vitamin K they eat. Now, the newer DOACs, like Xarelto and Eliquis, it's a whole different ballgame. No routine blood tests, no major food interactions. It's a massive, massive advantage. Whew. Okay, we have covered a ton of ground. So let's lock all this information in with one final super high-yield recap. Seriously, get ready to screenshot this next slide. It's going to be your best friend during your final study sessions. And here it is, your ultimate cardio cheat sheet. Let's run through it quick. ACE inhibitors, the ILs. Your keyword is dry cough. ARBs, the sartans, think less cough. Beta blockers, the ALOs, you got to monitor heart rate and blood pressure. Statins, watch out for muscle pain. Loop diuretics like furosemide, think potassium loss and dehydration. And finally, warfarin. You have to monitor the INR. Honestly, if you can just nail these key points down, you are in fantastic shape for the exam. And just like that, you're done. You have officially powered through the absolute core cardiovascular drugs that you need to know for the PTCB. Seriously, great job. Keep coming back to these concepts, keep practicing, and I promise you, you will absolutely own this section of the exam. Hey, thanks so much for joining me for this guide. Always remember our motto here, study smarter, remember faster, and pass with confidence. Make sure you subscribe for more of these high-yield prep guides, all designed to help you crush that exam. I'll see you in the next one.